So the first poster is from, well, it's from one of my neighbours in the Royal Glamorgan Hospital. The lead author is Sue Waller, but it's being presented today by Edward Matthews and Thomas Gruar, and they are presenting secondary care outpatient anticoagulation service redesign as a result of COVID-19. So I will hand over to you.
Thank you very much. I'm just trying to get the slide shared now. Can everyone see that there?
No, we can't. It's coming through now. Perfect.
There we go. Good.
Okay. Thank you very much. Thank you for that introduction, Simon. My name is Edward Matthews, and I'm joined with Thomas Gruar, who is here as well to talk about our service redesign that happened at the start of COVID, which seems like a very long time ago now, 3 years ago. Yeah, I will crack on and start it. So COVID pandemic broke out in 2020, back in March 2020. Like I say, it seems like a long time ago, but it's certainly fresh in our minds when it all broke out. So as you all know, a lockdown was issued and everyone was instructed to stay at home. And now this was a problem for us in our anticoagulation service here at the Royal Glamorgan Hospital, because we had around about 100 patients who were regularly attending for their INR appointments, as well as some DOAC appointments as well. And a lot of these patients were clinically vulnerable, so had a lot of comorbidities. So really, at the drop of a hat, we were faced with a difficult task, really, to try and get them safely seen whilst not putting them at jeopardy from catching COVID. So we had to mobilize quite quickly. So what this is really is just to talk about how we managed to do that and how we managed to cope with the challenge that COVID faced us, and the changes that we had to make, which are still effectively happening now. Some of the changes we've made are still in effect. So just to describe how that all changed and how we kept our patients safe. So this is just a graph to show how our patients attended for their visits for their INR. As you can see, most of them by April 2020, then most of our patients were clinic attenders. We had a few district nurses and a very few number of self-test patients who used their own device to test their own INRs, and but most of them would come face to face. Now, obviously, this was a problem. Our patients, a lot of them came weekly as well. So once the issue was, well, outpatients stop attending the hospital, we had to really quickly work out what to do with them. Initially, obviously, they still had to come to their INRs, but we were able to embark on certain things and enabled us to make sure that we could see them safely. So that was the situation in April. So the aim really was to, as I explained, to reduce the amount of face-to-face clinic appointments and patient contact in an acute hospital setting. And I'm now going to pass over to Tom to talk about how we went through our methods.
Okay, so like I said, we had a lot of patients who were coming in face to face, and all of a sudden we couldn't do this. So we had to figure out how to carry on managing these patients' anticoagulation without getting them in face to face, point of care testing if possible. So we had, like I said, again, about 100 patients at the time. So our first job is we just kind of went through our patient lists and saw who we had on our books, and then started exploring all and any alternatives that were possible for these patients. So this is a pie chart of the distribution of where patients ended up. So we explored quite a few different avenues, as you can see here. So some of the patients were transferred to the GP. Some of them started having their INR done by district nurses, so that 12% switched to DN, which was great. Our colleagues in primary care and the district nurse team were really helpful. And this This did help because it meant the patients weren't having to come into an acute hospital site where we were managing patients with COVID. But obviously, it meant the work was put onto our colleagues in primary care, and they were very good and very facilitating at this time. Some patients did remain in clinic. What we did, we moved from the Royal Glamorgan, which is treating COVID patients, to a smaller community hospital, which doesn't have an A&E, wasn't admitting any patients with COVID. Obviously, we were using appropriate PPE, social distancing. So these people who did remain in clinic, we did move it from a different hospital site. But again, these patients were still having to come in, so there was a little bit of risk there. The two that I'll probably focus more on, which were probably more successful, is we had a little look at what patients we could switch from warfarin to DOACs, because obviously you don't need your INR, your regular point of care testing for your DOACs, so that reduced the face-to-face appointments. And we also, when COVID started, there was actually a bit of funding available. So at the time, we acted quite quickly. We managed to get ourselves, I think it was about 30 machines that patients could do self-testing with their INRs. So we had a little look through our list and had a look who we could switch to DOAC and who we could switch to self-testing their INRs. So the patients who we switched to DOAC, we had a little look through, and we had a few patients. We like to think we're quite proactive anyway, but for whatever reason, we still managed to identify a number of patients on warfarin who could be appropriately switched to DOAC. These were sometimes people who had been very stable on warfarin, so the benefits of the DOAC were not that great for them. It wasn't that inconvenient because they were only coming every 12 weeks. There were people historically who'd been put on warfarin and quite liked coming in for their INR. They liked the reassurance of having vitamin K, the reassurance of having a number. And probably there were just some patients who'd previously maybe just not been considered. So what we did, we went through and identified patients who could potentially be switched to a DOAC. If it was straightforward, so we did have some patients we previously offered a DOAC and they said no for whatever reason. But then with COVID being around, they were a bit more willing to undertake this. So if that was the case and they were fairly straightforward, we were all prescribers in the team, so we would undertake the prescribing, discuss which DOAC they would like, we would prescribe it ourselves. If it was a bit tricky and we wanted a bit of reassurance, we would go back to the initiative consultant or our hematology consultant just to make sure that what we were doing was appropriate. Then we would invite the patient to the clinic. We could give them a bit of counselling and written information about the new medication that they chose. We could then take their INR and according to the INR, switch them over to a DOAC. Once this was done, obviously they didn't need any more follow-up INRs, and the follow-up with full blood counts every 3 to 12 months and telephone follow-ups, that could be provided again by primary care, so they didn't have to come back to the hospital again after this initial appointment to get them switched over. So like I said, we managed to source a number of self-testing machines. And what we did again, we used our kind of knowledge. We went through our patients, the list of patients we had. We managed to identify patients who we thought would probably be suitable for a self-testing machine. This was kind of based on what their risk was. So the reason they were on anticoagulation, ideally this would be a patient who is high risk and is on anticoagulation for a long time, so long-term treatment, so that they'll get the maximum benefit out of having a self-testing machine. We did also have to consider whether we thought the patient would be able to do the self-testing, and we did have a few, unfortunately, who probably wouldn't, but most people were. Once we'd managed to highlight the number of patients we thought would be suitable, we gave them a phone call and just kind of discussed the idea with them. If they were keen, what we did, we invited them into clinic, where we managed to provide face-to-face training with the self-testing device. We showed them everything, how it worked. We showed them the technique for getting a point of care result, had them go through it with us, make sure they were comfortable and confident with it. We then had contracts to say that they would behave appropriately when they were monitoring their own INRs. We provided lancets, strips, sharp spins, all the other consumables to go along with it. And once they were trained, signed a contract, they went home, and the next INR they would do at home, get the result at home, phone it through to us, and we would then dose and give instructions via the telephone for the follow-up appointment, which again meant that they didn't have to come into a hospital. We did also, I think, have 1 or 2 patients who we were able to give the machine to them, and they were a bit more maybe tech savvy, and there was online videos. So they were able to do online training without even having a single face-to-face training. So it's quite a good system actually, and it actually worked quite well.
So for the results, very positive. 11 patients we identified that were appropriate to switch based on the methods just described, and they were all successfully switched. We didn't have any issues there. And I think one of the things that we realized once we were quickly trying to switch people to DOACs was that we probably should have done this sooner. It was a good prompt for us. And even now, I think it's still quite easy when you get a patient that comes through on warfarin and to just, as we're a secondary care intermediary service, essentially, we see them, we'll dose them and then transfer them back. But if you're critically looking at everyone on warfarin and why you're on warfarin, always asking the question, I think you can do a lot more. So I think we could have had some of these switched earlier, but COVID was that kind of catalyst, if you like, for us to do so. So yeah, we had success with that. And as the self-testers as well, almost everybody were successfully trained. That you think about the time back to March and April 3 years ago, people were very terrified of hospitals. So that was a good incentive for them to become competent using these machines, which is quite daunting for some of our patients. Some of our patients that hadn't done anything like this before, but there was fear of them coming in to face-to-face appointments made them want to do it. And a lot of people's partners as well were able to help, or younger family members were also on board as well, so they were able to help and maybe sometimes administer DNRs for their family as well. Of the 2 that didn't, one of them in particular sticks out because we tried for a long time to try and get to compliant with the self-test machine, but hours of training, hours of trying, eventually got it, but then came back to clinic in tears saying she didn't want to, and we exhausted all options there. Couldn't switch to a DOAC because she was a valve, couldn't go to the GP because she's very unstable, so the GP wouldn't dose her. So she accepted that she'd have to come in and use the appropriate PPE. So, but on the whole, we managed to get people, and you can understand why people would generally like to be able to do their own tests and phone it in. It's just a lot easier on so many levels. So kind of a bit past that. So that's just a graph to show from the poster what I've just described. And then this is just an overview of our clinic spread between April and June. You can see a lot more non-face-to-face, most notably the self-testers. The ends were very, very helpful, I must say, during the whole thing. They had an increased workload because of the way everything was sort of moving away from secondary care. So, but they did still agree to accept some patients who were not suitable. I mean, again, perhaps COVID was a catalyst for them becoming DNs because we did have quite a few frail patients attending clinics, perhaps when they shouldn't have been. So, and then the other means of testing that is shown there, not really too much different. You can't really do too much about the dialysis patient. So that's the headline figure between April and June 2020. 156 appointments at the acute hospital site were avoided due to patients being able to self-test. So all very quickly done, and I think successfully.
Yeah, so just like I had said, in conclusion, the aim was successfully met. We managed to reduce the number of routine clinic appointments we had whilst continuing safe and effective treatment for these patients. And ultimately, there was a shift in patients coming in face-to-face to being managed closer to home. Obviously in line with things like healthier Wales, where patients need to be involved in managing their care, managing patients in the most appropriate setting. We also, again, we ensured patients are on the most appropriate anticoagulant. So, yeah, again, switching patients who historically have been on warfarin to DOACs. And there was a high rate of success of training patients to do self-testing. So this was relatively new to us. We had a few patients who'd been a bit more proactive previously, who've got their own self-tests. This was the first time we'd sourced a number of machines and undertaken training on a larger scale, and it was really successful. further work. So this all happened very quick in a time when things were changing very quickly with COVID. And what we did was good. I think now the further work is we've got good feedback from our patients who self-test. They're very happy with it. There's already evidence the patients who self-manage INRs have the better, if not have the same, if not better outcomes. So for us is to work on this, maybe a bit more formal, have a look at what the benefits are, and then further work as well. So as I had mentioned, we're a stabilization service. So we take patients who are maybe newly started on warfarin or their INRs are difficult to manage in primary care. We should stabilize their INRs and then transfer them back to primary care when suitable. So we now have a number of self-testing patients, but the services in primary care may be still lacking the resources to manage a greater number of patients who self-test. So if this is something that we're going to look at rolling out on a larger scale, we need to make sure we know what the benefits are and how that's going to be handled across all sectors of care, really.
So, thank you. Has anyone got any questions? Our next slide has got the poster there, so you can see it. That's what we're talking about, I suppose.
Okay, thank you, Edward and Thomas. Very interesting and enjoyable talk, and excellent work done there. So we have had a question put through. It's 3 parts to the question, so I would just put them through as they came here. First of all, how did you assess for suitability for self-testing?
Okay, so we had a list of all of our patients, and we know our patients quite well. Our caseload isn't enormous, so we know them all quite well. So ideally, we were looking for patients who were on anticoagulation long term, because we thought they would probably have the most benefit of having a self-testing machine. We also went through comorbidities and kind of unofficially risk class. What is their risk of coming into hospital? What is their risk effectively if they come to hospital and catch COVID? So who is the highest risk of that? And then through, again, like I said, our service previously was a lot of face-to-face contact. So we knew these patients quite well, and we had an idea of which patients would be able to self-test. So we kind of risk classed a bit rough and ready. This was all happening very fast, but they were the major kind of considerations. And then we also looked at how often patients were having INRs. So if somebody's having 12 weekly INRs, potentially less benefit than somebody who's having 3 weekly INRs with a valve. So it was all kind of unofficial, but they were the kind of criteria we did use to risk assess.
So by doing that, you'd understand which ones had the cognition and dexterity. You mentioned that you got a lot of machines. So was it that you had the NHS funded these machines, or did people buy them?
There was a pot of money. There was a COVID fund, basically, and we put an application in for a set number of machines, which was accepted. And I think it was 30 machines we initially got once this funding came out, and that's how we got the machines.
And a follow-up question to that from Kalisha Russell is, was it the patient's responsibility to calibrate the machines?
So we do 6 monthly calibration checks as well. So they do have to come back every 6 months. We check the technique, we check the history of the machine. We then get them to do an INR. We do an INR on our machine just to kind of calibrate. And we do that every 6 months as part of the agreement.
Okay. And from the indications for why these people were anticoagulated, it'd be interesting to know the indications of those who were considered for a switch and those who weren't switched to a DOAC.
So we initially looked at AF, and we went through most of those patients first. We have got quite good links with our cardiologists, so we were able to sort of have a good idea about which ones were suitable for a switch. But we could look at echoes and things like that, but we always got the cardiologist, the initiating cardiologist, final say on it, so that we were able to safely switch. Long-term VTEs as well, that was where we went to next. And we made sure we covered all of those. If there was obviously short-term, then we would look to switch them, but perhaps not as urgently. And we weren't looking at any of the above for switches to DOAC.
Thank you. So there was a question here: did you convert any antiphospholipid lipid syndrome patients?
I can't, off the top of my head, can't remember. I think there may have been. I don't think we did. No, I don't think that was included because at the time I think there was that MHRA warning.
Okay. Thank you. One last question, and then we'll be moving on. I mean, this occurred at an extraordinary time where we also had a lot of money being thrown at various aspects of the COVID pandemic. You've talked about looking to develop this further. What is the sort of health economics of this? Do you have an idea as to the sort of costings and whether they're comparable with what we've been doing recently?
I think that's probably what we would need to do next, is to get a bit more solid figures. We know how much the machines cost now. We know how to source them. We've got, a good amount of data of how many INR tests these patients have had, how many, and then I think the next step would be looking at comparing that if they were still coming into clinic and using that to go forward to try and carry this on, show the benefit of it in a bit of a more robust manner.
Okay, thank you very much. I think now would be a good time to move on. So if I could just thank you, Ed and Thomas, once again for an excellent talk, and everyone who's been asking the questions.